Okay, guys. So I'm just going to go through the presentation here on the Capafons study. So this is one of the studies you need to know in Unit 2 for learning theories. So I've spoken about systematic desensitization, SD, and some principles about how it works and the theory. Now, this is one of the studies that you need to talk about in the exam. So this was done in 1998, so relatively recently. There has been lots of previous research in this. It's considered, an effective form of therapy. So we looked at some previously, and I'll mention them again. There was a review in the 1970s about, all the different studies that had looked at this, but most of these are theoretical. And there haven't been as many studies with a practical emphasis, although that has changed somewhat over the years. We looked at the Lang study. So a group of college students suffering from a snake phobia. There was a benefit to them. Their fear rating fell 6 months later. The Rothbaum studies, which is kind of important background research for this study, participants with the fear of flying, after their treatment, their anxiety levels were lower than people who were just a control group who didn't have any fear of flying, showing a significant difference as well. So a few studies there that support what we're going to talk about next. McGrath as well, 75% of the patients treated for anxiety disorders responded well to their treatment. So again, key research in this area, all to do with the practical application of systematic desensitization. So why this study in particular? It's a practical application of SD, and it's a very specific phobia, the fear of flying. So again, looking at something which has a practical use for a lot of people. And also a quantitative and qualitative. Remember, quantitative dealing with numbers, qualitative, again, dealing with non-numerical data as well on how this therapy was effective. So a kind of detailed study that would be very helpful for a lot of people. Now, this specific treatment, why is it a useful treatment for fear of flying? Confrontation exposure is not enough to reduce fear. So something like this, if you were to just force someone to go, if you were mean enough to do that to someone, force them to fly every day for a year, that may not be enough to reduce their fear levels. Now, some people might get to a point where they tolerate flying. I have friends I've flown with who really don't like flying, but if there's no choice, they get through it. But you can tell that they're very anxious throughout the whole process of flying that day. Now, examples of this, people who take an average of 30 or 40 flights a year. Some people might have to fly for business, for their work. They might need to go on work trips frequently. So this is an issue for them. Now, SD incorporates exposure, but with self-efficacy. What this means is that patients have a feeling of control over the situation. They might not like flying, they might not enjoy it, but they can actually kind of break down the process and have some control over their emotions around flying. The other benefit as well is it can be applied in images. So maybe, you don't have to force someone to actually go on a flight, on a physical plane, but this in vivo meaning direct experience, it's not necessary. You can start this process again by showing people pictures of planes or videos of plane journeys, and we'll talk about how that was done in the study later. It is also not as heavily dependent on the therapist. So this kind of treatment, SD, is very much, it puts it in the patient's hands, that they have exercises they need to work through, and it's done in levels, so that once they feel confident at a certain level, then the exposure gets more and more gradual. So the therapist is just there to guide, not necessarily to interpret or, to give lots of details on why the person might be afraid of flying, but is there to help the person think, okay, how can we solve this fear of flying in a practical way? So this is done, again, minimizing the effect of exposition. So gradual steps, you don't just throw this person onto a plane, and hope for the best. It's done very gradually. And that's important because it means if it's done in this slow, gradual, and patient way, it's much more likely that patients will actually complete the therapy at the end of it. So again, a reference to other studies as well that you might want to look at: Canton, Howard, Sank, Scrivener, and all. So these are other specific studies to do with flying as well. So the sample of this study, who was in this study? 41 people with a fear of flying. So all the people in the study, again, were very specific. 20 in a treatment group, slightly more females than males, average age of around 30, and another 21 in a waiting control group, slightly older, but a similar kind of sample. Now, how they were recruited via advertising, radio, newspapers, and TV, in Spain. So looking at this here, have a think about if there's any problems with this sample, any potential issues with this sample. Can you generalize this sample, for example? So we'll look at that later. Now, all the people in this study were told they could take part in a treatment for fear of flying, and it would be free of charge. So this was the incentive. Why would people sign up for this? They weren't actually getting paid, but this kind of treatment might have been expensive for them, or there might have been long waiting lists for them to get this kind of treatment with a doctor. And obviously, it's a kind of phobia that doesn't affect their day-to-day life, so people probably would have been less likely to actually do that as well. So the kind of instruments and tools that they used, they had a diagnostic interview with patients. They had fear of flying scales, so there were particular scale questions that they used. They also had a video of a typical plane journey. So they showed people the video of someone taking a taxi to an airport, going through check-in, getting their tickets for the flight, going past security, boarding the plane, all of the kind of the steps that you go through when you go on an airplane journey. Have a think about, why do you think they might have shown a video like this? So some of the reasons, again, could be trying to get the patient in the setting of an airport. So maybe even just the thought of, the sounds of the airport, maybe, the announcements of the airport could be enough to get a fear response or some kind of anxiety, because it's similar. It's something that would be associated with the airport itself. There are also psychophysiological recording devices that they used. So things like measuring heart rate, skin temperature, muscular tension. Did people tense up when they saw these videos? So they were looking at all of these things as well. So quantitative data on literally how people's bodies reacted to this kind of stimulus. So to give you an idea, these are some of the questions on the IDG. So people were asked things like, how afraid of flying would you say you were? And they were given a scale, not at all or extremely. So there were kind of ranges of the answers they could have. Do you travel by plane when there's no alternative way to travel? Again, there are some different options here, ranging from no, I never, or I'm not afraid, I always fly. And other questions that were asked as well, there was a list of symptoms. So again, asking patients, do you suffer from sweating, muscular tension, tachycardia, which is kind of an irregular heartbeat, all of these different things. Again, no, sometimes, many times, always. So you can see how they collected data like this to get an idea of how severe was each person's fear of flying in the beginning. There was also something called an EMV scale as well. So different situations that occurred from takeoff, acceleration to touchdown of an aircraft, the flight preliminaries, again, going to the airport, obtaining a boarding card, things like that, and fear without involvement. So even seeing an airplane flying in the sky, or seeing an airplane on a TV. So there's a kind of a strength of effect. So, how much do these different things, cause this fear response in the patient? The other scales that were used, what they looked at, were EPAB scales. So, the catastrophic thoughts, did these patients, was there a fear that, engines could catch fire or a wing falling off, kind of extreme emergency cases? Was this something that was going through their minds every time they thought about flying? and also physiological anxiety. Remember, we looked at psychophysiological manifestations. So basically, things like, does your heart rate increase? Do you sweat more? Do you feel nauseous or sick? These kind of questions were asked to the patients as well. So the specific aim of this study: is systematic desensitization an effective treatment of maladjusted fears? Remember, we looked at what we mean by maladjusted, an irrational fear. Yeah, is the fear of flying, disproportionate to the actual risk posed to this person? And it's a cliche that's often said to people that you're more likely to have an accident on the road than you are in an aeroplane, for example. So that's one reason people give to say how irrational a fear of flying is. And specifically to investigate whether SD is an effective treatment for fear of flying. So is SD a good treatment for flying or not? So this is the specific reason for this study. So the procedure that was done, patients were interviewed on their own. They did the IDGV scale that we looked at, and the other scales were done on further interviews. So remember the first set of 3 questions, if I go back. Yeah, so these 3 questions here, these were asked in the first interview. And then the rest of the scales were done later. Because I think it would have been quite intense for people to do all of them all at once. So after that, then they went back and they watched a video and they had their psychophysiological assessment. So they did all the measures, measuring their heart rate, how much they were sweating, for example. Well, what they did, they set this up so that every participant had 3 minutes without the video, without the phobic objects, and then watch the video after being told to, imagine being as involved as possible. After they watched this video, they made another appointment, either to have the treatment or the next assessment. So everyone did the first steps, and then people were split into 2 groups, either the waiting group, the control group, or the treatment group. And if they were having the treatment, then they would have 2 one-hour sessions a week as part of their desensitization program, at least 12 sessions, up to 15, a maximum of 15. So this is quite a lengthy process. So 15 sessions was considered a sufficient amount of time for this therapy to be effective. And it used in vivo and imagination techniques of visualizations, but with an emphasis on a hierarchy of fear. So working through each step of their fear of flying, using relaxation techniques as well. So the results of this study, that they found there was no difference in any of the measurements between control groups and treatment groups before treatment. So basically people were generally at a similar kind of level. They carefully thought about the groups they had, that everyone was around a similar level of fear of flying before the experiment began. But then if you look here at some of these results, what do you notice from this table? What's interesting from this table? So when you're trying to interpret this table, have a look here where you see the stars. Now, at the bottom of this table, again, if you've brushed up on your research methods, you will see, at least 1 star, a probability level, of, let's say, p level of 0.05. Okay, very significant. 3 stars here, even more significant. 0.001. So you can see here across a number of measures that this reached, a significant level. There was a significant effect here going on. So there are conclusions you can draw from this. Now, here, if you compare the control versus the treatment group, going back here, this is just the treatment group. So if you had treatment for fear of flying, here are the p-values that you could see. A significant difference. People who were treated, after their treatment, you could see, in general, they were less fearful about so many different things. And you could even see here their heart rate. Physically, you could prove this as well. Their heart rate and their muscular tension went down. So it wasn't just self-reports. It wasn't just that they said they didn't feel as scared. They actually felt less scared here as well. And you see a similar effect here. If you compare the control group and the treatment group, so the group that didn't actually have any treatment, or at least were waiting for their treatment, and the group who had their treatment, and look at the difference here. Again, very significant over a number of different categories, even more significant for heart rate here as well. That's quite interesting. Yeah. So have a look at this data and you can see all of the different things and how these are affected. This is taken from this table, the summary of studies. So you might visualize this, this might be easier for you to visualize. It's the same data as what I just showed you, but it might be easier for you to interpret in this kind of table as well. And so this was the comparison between the treatment group before and after. These are the two comparisons here. So what are some conclusions that we can make from this? Only 10% of patients who had the treatment did not have a significant reduction in fear concerning their flying. That still means there's 10% of people that didn't respond to this treatment, but that also means there were 90% of people who did have a significant reduction in fear. So it's quite an effective treatment for this. Now, what was also concluded was the simple passage of time did not help reduce phobias. So the people in the control group, who didn't actually get this treatment, just through the passage of time, just by being in that group but not having treatment, didn't make any difference. They weren't less scared. So you could make the comparison between people who had the treatment and people who didn't. The people who did, again, showed much more improvement. Why was it successful? There were specific things that they did when they carried out this study. So breathing and relaxation techniques, very rigorous. People on the study were encouraged to practice this at home. And again, the belief of the researchers is that these relaxation techniques, are incompatible with anxiety. Remember this theory in systematic desensitization, reciprocal inhibition. You can't feel fear and relaxation at the same time. So if the relaxation techniques were being practiced, people were less likely to have a fear response because you can't be relaxed and scared at the same time. They're opposite feelings. They also used a particular number of stimuli. So they had between 25 and 33 different things that they used in this therapy. So you don't want to have too many of these things, but you don't want to have too few either. So the researchers think actually they found the right balance between having just enough stimulus in this study to benefit people and to motivate them, and to have enough of a gap between each level of the therapy for them to progress. And this inclusion of gradated tasks in real situations provides an exposition in situ. So basically, having the clinical sessions, having the theory part with the therapist, and actually having real practical exposure to images of airplanes, or stimulus that were to do with airplanes. These are some of the reasons why it's effective. That patients didn't just talk about their fear, but they practically did something to try and challenge their fear as well. So if we're thinking about how we evaluate this study, like I mentioned, 10% didn't benefit from the study. So there needs to be further research on why did these 10% of people not benefit from the study? Is there a deeper reason? Is there a deeper fear that some people have of flying that SD just cannot solve? Or are there particular individual differences that some of the participants had that we don't know about? This is something that needs much further research. How generalizable is the study? It was done in Spain, in Tenerife, 41 people. Do you think that's a big sample or a small sample? It was a volunteer sample as well. What do you think the issues are with the volunteer sample? So people voluntarily did it, but do you think that means they recruited a variety of people or just the ones who were interested? So you have to think about how they advertise. They advertise on radio and TV and newspapers. So again, did they think about who they were targeting? Who was reading these newspapers or watching TV? What time were these adverts on TV or on the radio? So, again, who were they capturing for this? Who had the time to actually go and have these treatments? Maybe some people who were afraid of flying, but were just too busy to actually go and have these sessions. So again, kind of you have to consider all of these things. Another point I make is the profile of frequent flyers. Maybe the people who flew a lot, maybe they fly a lot for work or for business, didn't have the time to do this study. That would be an interesting subgroup of people to look at. Or maybe the people on this group, there were disproportionately more people who fly more. So they're not representative of the wider population. Do people in other countries suffer in the same way? Does this kind of therapy work better for some cultures rather than others? So these are things you can think about when you're evaluating the study. Is it reliable? So there were clear and defined assessment measures and scales. There was quantitative data that was used and numerical data, and the procedures were standardized. So the participants had the same instructions, did the same thing each time. So there was a degree of reliability. If you were to try and copy this experiment, you would have everything you need to do that. Does it actually apply to real life? I think in general, this is one of its strengths. 18 out of 20 participants, it worked. It actually worked for them. It made a difference to their quality of life. So it's a concrete example of a real life problem that we can attempt to resolve. But if we look at this in wider terms, there are American studies that show about 25% of people, 1 in 4 people, are uneasy about flying. They don't particularly enjoy flying. And about 6.5% of the population have aviophobia. So they actually have a fear of flying. So 6%, 7% of all Americans genuinely have a fear of flying. That's a lot of people. That is a big group of people. Now, we are basing our conclusions on 41 participants in a study in Spain, but there are potentially huge applications for this. There could be replicated studies in different countries using the same procedures. But we also have to think, is flying the same as other phobias? Maybe this is a good treatment for phobias like flying, but maybe a phobia of buttons or a phobia of snakes can't be treated in the same way. Maybe you won't see the same success. So that could be an interesting comparison as well, to see how effective SD is at treating other phobias other than flying. And again, we mentioned individual differences. So what are the differences between each participant? Why do some people, for example, not benefit from this therapy as much? Why do some people have much stronger reduction in their fear compared to others? So we also need to consider this as well. How valid is the study? It's low in ecological validity, but high in experimental validity. Again, this is kind of, let's say it was done in a therapeutic setting. This wasn't done on an actual scheduled flight, for example, but there were very strict controls in place. So again, other researchers could use this study, and it was testing what it was supposed to. So there was a clear process for what it was testing. But the environment may have been unnatural for participants. Again, going into these therapy sessions, would they behave like they normally do? And obviously, the participants were motivated to be less scared of flying. So some of them may have wanted to say yes, that they were feeling less scared. Maybe they weren't. But this is an issue with self-reports, that they could cause potential problems. So again, this is a particular issue. Also, social desirability and demand characteristics. So they might have told researchers that they're feeling better because they think that's what the researcher wants to hear, that they want them to know that they're feeling better, that they're not as scared of flying, but maybe they're not genuinely feeling that. So this is a potential issue in terms of validity. Ethical issues for a study like this. They didn't need to deceive any participants because patients were highly motivated. People wanted to cure their fear of flying. So the researchers could advertise freely to say, look, there is a treatment that we can try, but obviously, the results of this they will look at later. They had the right to withdraw at any time. Full consent was given. It was very clear for participants what this study was about and how they would be treated. Protection from harm. Now here is a kind of more nuanced point, because again, we're dealing with a fear, a phobia, so people who are scared of a particular thing. So this has to be managed in the right way. But I think the researchers carefully thought about this. The kind of questions that they asked to people before the study, if you remember. Now, if there was someone with an extremely severe fear of flying, and this was kind of picked up during the protocols, during the questions before the treatment, the research group may have considered not putting them on this study because it may have been too anxiety provoking for them. So this was carefully managed throughout the process. Now, the theory behind SD is that there is gradual exposure. So this gradual exposure, where it's kind of, let's say, more severe as you go along, but it's done in a way where it will only be done if the participant is comfortable with the next step. So this is one way that protection from harm was managed. And there was a careful design of procedures, again, that protected the participant from excessive anxiety as well. So this was all kind of carefully considered, but ethics is an important note to pick up on here as well. So this was the study in a nutshell. I'm going to just go through a few possible exam questions. I'm not going to talk through them on the slide, but then you can actually see some of the answers. So you can just kind of pause it as you go along. So one particular example, I'll just go through this one. So Maria has a phobia of cats, which means she can no longer visit her friend Alice, who just bought a cat. So evaluate systematic desensitization as a treatment, a therapy for Maria's phobia, and make reference to the context in your answer. So looking at this question, consider how you're going to break down the question. How many marks are there for this one? So there are 12 marks available for this question. So you need to describe, you need to evaluate, but also remember the clue. When you see someone's name in the question, when it's referring to someone, then you also need application points as well. So if you split these, here are some of the examples of points you could make. So you can pause it here, and this will give you an idea of how you might structure your essay. And remember, you need 4 points for each one. There are also additional marking points you can get that the examiner suggested, but these are what are taken from the actual Edexcel exam scheme. Okay, so that's one example of a question that's set for you. So you could practice doing that one. Another example is a simple evaluation question here. So you can pause it here if you want to look at this question and see how you're going to break down this question. Now, an evaluate question here, it's 12 marks. So you would break this down into what? 6 marks of description, AO1, and 6 marks of AO3 evaluation. Here are some description points that you could use. And here are some evaluation points that you could look at as well. Okay, and again, there are other valid evaluation points you can use. We've talked about some of them as well, so you could also use those. But this will give you an idea of how you might answer a question like this. Okay, other examples, you can try these yourself. So here is a question from the January 2019 paper. Again, look carefully at the number of marks available here. Here is an example from June 2018, an 8-mark question here. One from October 2016. One here from January 2017. Okay, so those are some examples. These are some of the examples that have come up in recent exam papers. Again, you can look on the Edexcel website. I've given you the link for this already, so you can have a look at the mark schemes. But try to do the questions first based on what we've looked at. And then once you've done those, look through the mark scheme to see where you could have improved it. And I will also give you the feedback and mark these for you. If you want some further links, you have the full paper here. You have specific learning resources here. again, a few other notes you can look at, and a summary of studies. So this is taken from Edexcel. It gives you a brief summary, close to the exam. You can revise that as well. I've also attached a video link about systematic desensitization on YouTube. You can search on YouTube, see some videos of how it's done in real life, in practice. So hopefully that's enough for you to get on with for this week, and it clears up, what we mean by systematic desensitization, and you've got a good understanding now of the study itself.